by introducing Dr. Tewari, that will be talking about unraveling the biology and impact of COVID-19 and prostate cancer. I had the pleasure myself of meeting Dr. Tewari, who has been an excellent physician and really, really, really cares about this issue with men um, deeply. And it has over 250 uh, authored articles and has written numerous book chapters and on prostate cancer and robotic surgery. And uh, we are honored to have Dr. Tewari, the chairman and department of Mount Sinai Hospital, here with us today. And we would like to welcome Dr. Tewari. And without further ado, Dr. Tewari, could you please introduce yourself and let us know a little bit about this topic?
Thank you, Lewis, for arranging a platform of this kind in which we can talk to people in the trenches themselves. Normally I talk about prostate cancer, I talk about PSA, I talk about how to tackle this cancer. But last 1 year has been very interesting. What actually happened, the whole world changed because COVID touched upon almost every aspect of our lives. I personally ended up catching COVID while tackling being a doctor. I ended up in an ICU for some time. I came out. And in that process, I learned a little bit about this disease. And during that learning, one thing became obvious, that there is something very common between COVID and men, COVID and prostate cancer. And that became an very kind of an interesting journey for us because on one side, my lab, my research, my clinical program was focusing on how to diagnose prostate cancer early, how to tackle it, how to do the nerve sparing, how to do a targeted biopsy. And on the other side, some scientists in my lab started looking at why COVID is happening more often in men. Why? COVID is happening more often in men, especially if they have prostate cancer. And what happens to a man with prostate cancer also happens to have COVID. These were interesting questions, and what we found was pretty concerning. So I want you to kind of learn a little bit about this disease, and I'll see if I can find this slide deck for you. So all of you know that COVID is a virus, and that virus has many proteins. And one of the proteins which is very commonly present in COVID is known as spike protein. It's like multiple spikes are around a football, and these spikes go and attach to our cells. Each one of our human body has about 53 trillion cells in our body. Some cells are skin cells, some cells are lung cells, some cells are blood cells, some cells are bone, some in kidney, liver, heart, prostate. But these all cells have one thing common, and that is known as an enzyme known as ACE, ACE. Many of you who have to deal with the blood pressure issue, they know they have to take a medication known as ACE inhibitor. That's a blood pressure medicine. That ACE has an affinity, it's like a glue to which this COVID comes and attaches. So COVID's spike protein comes and attaches to a cell to that ACE receptor. But it cannot go inside the cell till there is a door opener. And that door opener is known as Tempress 2. I'm deliberately giving you two names. Remember ACE, Spike, and Tempress. And guess what? Who has more of Tempress 2? Men with prostate cancer have highest level of Tempress 2. And this mini key allows COVID cells to get inside the cell. And once it gets inside the cell, it kind of takes over the cell, and cell is supposed to produce urine in the kidney and produce blood in an RBC or produce enzymes in a liver, but it turns all those cells into only one machine. It tells the cell, make more COVID, make more COVID, make more COVID. So COVID got inside the cell, hijacked the cell machine, and one COVID produced 1,000 more COVID inside the cell. And after a while, these all COVID are released and they go to the neighboring cell and to the neighboring cell. And that is where the body's fight starts. And it's very important for us to understand what this is, what's going on here. So the very fact that men have a temperance too, and that is an enzyme which normally is needed because we have testosterone. Testosterone, in order for it to work in a body, to give us muscles, to have a prostate, to have a libido, needs temperance too. And the same temperance too is being hijacked by COVID to get inside the cell and do the more damage. That is the reason men with prostate cancer or a prostate risk are more likely to have COVID, more likely to be hospitalized when they have COVID, and more likely to have a ventilator discussion if they have COVID also. So that's the reason we were very suspicious. I started reaching out to all my patients that if you have a COVID symptoms, or even if you don't have it, be the first one in the line to get the COVID vaccine and all those things. But then the second part is, who has more ACE inhibitors? That enzyme ACE I was telling you, people who have blood pressure, people who have obesity, people who have diabetes, and people who have chronic other issues, they have an upregulation of the ACE. So we have a target on the cell which attracts the COVID. We have an enzyme which allows COVID to go inside the cell, and the rest is a history. That is the reason why men have more COVID and men with prostate cancer have more COVID. And that's the reason we have to do everything possible to kind of mitigate that, do all the things which CDC has been guiding, do all the precautions we can, take as and when available vaccination, because that is one thing which will kind of control this process. But there is another aspect to this. Once COVID goes inside the body, the mere fact that it has affinity for prostate, it can make prostate more inflamed. And if prostate is more inflamed, the first thing which will happen, the PSA values can start getting into a jumpy mode. And then the second thing which can happen, if inflammation continues for a long time, even if someone doesn't have cancer, becomes more prone to the cancer. So COVID on one side was getting into men because they had that enzyme. On the other, if they had it, they have a little bit long-term effect on that. So not only that we talk about the long haulers in terms of breathing issues and the fatigue issues, but men with prostate diseases and men with prostate cancer can have a very compounding effect of COVID. So that is the message, and I wanted it to highlight that men has to be super cautious. I want you guys to ask me questions as to how, what to do, what are the normal guidelines here. I can talk about science, but I really didn't want to scare you out, but I wanted to give you solutions. And that's the message. Don't ignore COVID. Men have a special affinity, but there is a lot which can be done. I'm really wanting to answer any questions which you guys have. We wrote about 5 or 6 papers on this topic itself last year. And with my personal experience and my team's research, I really think watch out for this.
Well, Dr. Tewari, I wanted to say that I myself was extremely concerned when COVID started, because I was also in the midst of trying to get in to get my surgery, because I was going through prostate cancer, and uh, I immediately was in shock when I saw you in Channel 5 talking about, the dangers of, if you contract the COVID and prostate cancer, because it seems like there is not at the time, and even here, we're over at Orange County, New York, and even here, we don't quite seem to have this type of information out there as we should, uh, because it seems so important. I've met so many families and men from all walks of life, and I've met a couple that are of minority, and uh, I was I I was um, I was able to take the vaccine that is out, and I it is so important. I've been trying to kind of tell other men of color the importance of getting vaccinated, um, but um, but also the importance of um, the high indices rate that we have with prostate cancer, and how they should go and make sure that they know what their PSA count is. So, what is your outlook with men in the minority community? What are you facing on over there?
So I think you touched upon one topic and you have posed a question about the minority. I will touch upon both. So the first discussion is about, while I was talking about that men with prostate cancer have a more likelihood of having COVID and then bad outcome out of the COVID. Other thing is, we get patients with the cancer and cancer cannot wait. So last 1 year, I must have treated close to 1,000 patients. Some of them got biopsy, some of them got surgery, some of them just were washed, some of them had radiation. But these 1,000 patients couldn't wait for COVID to finish because their cancer every couple of months was growing. So we created a protocols on how to triage. There are some patients we had to do it, and we did it very safely. I mean, I think we out of these 1,000 patients, we were very lucky. I mean, I think we did it very classy way, and we had a safety protocol. We screened them, and we got the COVID testing before, we got the COVID testing afterwards, and we tackled their cancer. And people have beaten this cancer in just last 1 year, and we became busier than we were in 2019, just because there were so many patients and they didn't know how to tackle the COVID. We figured out how to tackle both COVID, prostate cancer, and both together. So that was the one aspect. So protocols were written. We wrote a whole paper on how to triage patients with cancer, not just prostate, bladder, kidney cancers, as to which one can be ignored, which one needs to be prioritized, that kind of a thing. Then there is an major interest of my program looking into men with color and what happens to them with prostate cancer. And it is true that men with color have 1.5 times greater chance of developing prostate cancer and have about twice the chance, if they get prostate cancer, of dying due to this cancer. So there is an increase in mortality in men with color with the same cancer. And that is a very intriguing question in my mind. And I have been studying that for last over 20-25 years. Reason I got interested, I was practicing medicine in Detroit. In Detroit, there were 40% of my patients were men with color. They used to work for automobile industry, either Ford or Chrysler or GM. But the mortality rates and the incidence of aggressive cancer was very high. So I started getting interested in as to why that is happening. And I can give you the summary of what I found, and that can be applied to any ethnic group. There are, so when cancer happens, cancer basically is a disease of genes. As I was saying, we have 50 plus trillion cells in our body. These cells have genes within the cell, and these genes, they tell us what to do. So the lung cell tell us to how to breathe, and heart cell tells us how to beat the heart. Prostate cells tells us how to produce PSA and other chemicals. While these genes normally produce the normal machinery for the cell, sometimes they become defective. And when they become defective, they go into a kind of an panic mode. And in the panic mode, what they do, they start dividing. So one cell becomes two cells become four become 16, and very soon they become billion cells. And if it started in a prostate and where there were only supposing couple of million cells, and suddenly one more billion cells came up, where do they live? These cells start breaking out of the corners in the prostate, and they try to find and go and find a new home in the bones. Some go to the liver, some go to the lymph nodes, some go to the lungs. That process of uncontrolled cell division is what we call, it has become a cancer. So this cancer process is driven by many enzymes, many chemicals. And if you have 20 different people who had prostate cancer, some will have it because they have a little bit of an hyperactivity of testosterone. Some will have it because they have a little bit of a derangement in the metabolic pathways, what we call insulin pathway, meaning how they manage the sugar. Some will have because they have a defect in their DNA repair pathway, like ladies get the BRCA gene, Angelina Jolie discussion that they get breast cancers. Same thing can happen in men also, that their cells cannot repair themselves, and that can cause cancer. Some will have it because they have inflammation going on. All of you are aware that people who were the first responders for the ground zero, prostate cancer is a risk factor for that group. And that happens because of exposure to certain chemicals, which resulted in a lifelong inflammation. So, what point I was making, that 20 different men will have the same cancer, but their journey of getting a cancer may be very different. Some may be sugar addicted, some may be hormone addicted, some may be chemical addicted, some may be radiation induced, and some may be inflammation induced, and some may be virus induced. So when we started looking at why there were differences, so we do realize that there are certain metabolic and molecular differences in prostate cancer when it happens to men with color. They tend to be more inflamed. If I have to summarize one thing, they are more inflamed cancers. But that is not the end of the story. Inflammation doesn't mean more aggressive. It means they are different. Second thing which we found, that men with color also happens to have sometimes more than one problem at the same time. The diabetes and blood pressure are distant cousins of the cancer, and they also are kind of in moving around into the same body. And if it is there, this cancer gets a little edge over the body, because body has to deal with not just cancer, but it has to deal with hypertension also. It has to deal with a sugar problem also. So, and these two are manageable. So the good news here is these two are manageable, but that happens to be the reality right now. The third thing was men with color were little reluctant in going for a checkup, meaning they were little bit, nothing wrong can happen to me and I don't need to go for a checkup. And cancer is one disease in which you win by being afraid and you lose by being too brave. Meaning, if you don't go for a checkup, you will never find a cancer which is curable. And if you wait for cancer to declare on itself, then usually it is little late. So men with color needed an kind of an reminder. They needed a role model to tell them that, you know what, you need to go for a checkup. All these three things combined, the differences in the molecular type, attitude towards healthcare seeking behavior, and comorbidities like blood pressure and metabolic syndrome and diabetes, that combination, I think, is responsible for why they tend to have a more incidence of cancer and definitely more aggressive cancer. And that is the reason we have recently launched a program in which we are creating a mobile unit in which we will send the mobile unit to places of worship or schools or the barber shops so that we can get the checkup to them, so that at least we can overcome one problem, that they are not coming to us. You don't come to us, we will come to you. And that's the mindset. So all combined, these are the reasons, and many of which are actually actionable. We can make some changes. And our lab is studying quite a bit of this molecular pathways, and we got lucky, as I mentioned, that Mr. Smith, Robert Smith, one of great philanthropists from in Black community, has given us a significant foundational grant to go and make that change. Hopefully that clarifies your two questions.
Oh, but of course, because I it's a it's a heartbreaking. You know of a good friend or a cousin or a dad, and you're trying to have this kind of like conversation of hey, you should go get checked out, and it's it's either they don't really believe that they can have an issue, a health issue, or some build up uh, their own theories of misguided distrust, which have no sound fact to it, and it's just so I'm glad that Dr. Tewari, you kind of basically you broke that down and what the situation was happening in Detroit, which is pretty much mirror image of a lot of places in the United States. Um, uh, so, um, dear guests, please ask the Tawari, take this opportunity to ask your questions and get some feedback from him, because this is so important. So I'm going to go on mute. Take your turn as you speak, and respect the others and be muted. All right. And I'm gonna leave this so somebody can ask another question.
Hello, Dr. Tewari. Thank you for your presentation. I just want to say that your research with COVID-19 and prostate cancer is so relevant now. My question, do you see any other viruses or you mentioned diabetes and other diseases. Do you see any other viruses that can also react with prostate cancer as well?
I'm not sure about in a one particular virus which is causing it. There were couple which were implicated but never have been proven. But certain chemicals have, and the cadmium and people who were exposed to Agent Orange, they have been implicated into that. But bottom line is, if inflammation happens, I think that itself can produce cancer down the road. It doesn't matter whether inflammation came from an A virus or a B virus, but if it is there and it is lingering in the body, then it goes on for a long time. That I think is definitely known.
There's some questions here on the chat. I don't know if you can see them. I'm just going to read some of them to you. There's one question regarding someone said that his father has prostate cancer, got surgery and it's fine. And his son has Down syndrome. He wants to know if the extra gene in his son is a risk of prostate cancer.
So Down syndrome is a distractor, but anyone who has a one member within prostate cancer in the family, and especially if there are other members with a pancreatic cancer, or the ladies have a breast cancer or a ovarian cancer, they have a high risk of having prostate cancer. I think Down syndrome, I'm not sure has any implication. If anything, it may reduce the risk of prostate cancer, but any family member having a prostate cancer, brothers, father, and close uncles, multiple members, that definitely increases risk of prostate cancer in the family.
There's a question here about someone was curious about plastics and weed killers. I guess, as you mentioned, any environmental contributors that may cause prostate cancer.
I mean, I think if you look at the EPA side, there are a lot of exposure which happens, but we can only talk about things which have been proven. And the ground zero exposure is a proven one. We are doing a couple of studies in which we are looking at air pollution level in Harlem and correlating with that with the incidence of prostate cancer in a particular community. But common sense says that less polluted life will live, less likelihood of having any cancer.
Dr. Tewari, I got another question for you. Would you say that regarding 9/11, I grew up in downtown Manhattan by the Lower East Side. It may not be directly right next to the towers, but it was fairly close enough where the ACs, there was debris cleanup, replacement of ACs, and for what my recollection, months, we could smell um, a very distinct odor, and it was a heavy kind of air that we were breathing for a while. Is it fair to say, and this is hypothetically, because that most of the downtown and the very near of the Brooklyn Bridge and that area was exposed to a certain level where men that predominantly not only responded to 9/11 but also lived in that area. Could this be something that increased their level over time with prostate cancer, the exposure?
I think they have studied very extensively based on the location, based on the airflow, based on the exposure. And even if someone was not a responder, they have identified certain zones which were very close to. This is a very good intellectual question. I mean, I think the problem is that this cancer is so common. 1 in 6, 1 in 7 men have it. So it's very difficult to attribute a particular cancer to a particular event, and especially if there is no marker for that. That if so that is something which is challenging. But these are all very interesting questions. I turned this into what we can do on a day-to-day basis to A, reduce risk of prostate cancer, or if we have it, change it into a victory lap. Meaning, and what I'm touching upon is in diet and nutrition and exercise and all those things. You can make a change that possibly reduces risk of prostate cancer and definitely makes you, if you have an early cancer, Gleason 6 cancer, I nudge them to be on an active surveillance. And I say, I do the surveillance, you do the activity. And activity is an eating right, exercise. So things which we can control, we should try to control. The behaviors which we can control, we should try to control, and that is to stay on and watch out for this cancer. Don't let it declare on its own. Go out, get checked, discuss at least options, pro and cons about what the PSA is, what happens, what if it is high. Not every man who has a PSA abnormality needs a biopsy. Not every biopsy turns out to be cancer. Not every cancer turns out to need a treatment, but there are some who need it and they feel very happy that they found it in time. So it's a very comprehensive approach toward this disease. All said and done, we still lost. 2 years ago, we lost 29,000 men. This year, we lost 33,000 men. If anything, the number has gone up. So it's important for us to be aware of the risk which we carry. What are the features we can do to reduce our risk? How to kind of reach out and study it or find out what my risks are. Imaging has become an important tool in our hand. It is really a game changer.
There's another question in the chat. There's a question regarding government funding. If you're aware of whether there's enough research, towards prostate cancer as compared to other diseases out there.
I think prostate is not the top, but there is some interest, and I think it's happening because of the awareness and the discussions which men are bringing it up. Men are a little shy. They don't talk about their problems, and they definitely don't go out and fight for it. And we have to be a little bit intellectually engaged in this process. Men take better care of their cars than their own bodies. Meaning, if you meet 10 people, they will be talking about what is the ball game, who's playing this Monday night in the football. And they sometimes will talk about the golf or talk about drinks. They will talk superficial. They will never talk about their PSA. They will never talk about their problems because we are wired like that. And if we are wired a little bit different and we say, hey, we can help each other, we still remain manly, but we can kind of find the problems, education, knowledge, sharing the data. That is what the mindset we need to change. And I think it's important for us to, we don't become weak by looking for a preventable thing. We become stronger that way as a group. And that ties to us having an advocate for and more funding. But bottom line is there is a funding. I mean, I think I am prostate cancer research group's member, and we have raised literally tens of millions of dollars to this research. This is how we are running this Robert F. Smith program. So there is some change, but there is a lot more to be done, and that will happen by men and people and veterans. They're writing to the government.
I have another question here. Someone's asking about how does prostate cancer affect transsexual men who have transitioned? I guess with whatever hormone therapy that they take, whether it affects whether they're potentially at risk for prostate cancer.
So let me reframe the question. So there are men who go through a procedure to change the gender identity, but in that procedure, one thing doesn't happen is that they still have their prostate inside the body. And on top of that, they get an estrogen kind of an hormone to kind of modify the body architecture. What happens now that it becomes very difficult. First of all, no one thinks about prostate cancer in that human. And second, the PSA is very suppressed because of the estrogens. And if cancer then comes up, it comes up as in what you call a castrate resistant cancer because it has already tasted the estrogen. So if it comes up to be a cancer, then it tends to be more aggressive. And I have a whole research proposal going on that this group of men needs a different kind of an investigation. And I'm a big believer that they need something like an MRI, because MRI can still see what is inside, even if exam cannot and PSA cannot. So this question is a very relevant question, and I am quite concerned that if the cancer will happen in that group, it will be more aggressive just because we haven't yet focused on it and we haven't devoted enough time in researching. And this is a kind of a research we need to focus on. And we have a very busy transgender program in our institution.
This is an amazing intellectual conversation because we're touching on so many aspects that are affecting different men of different walk of life, but all through what we're living through with this pandemic. Um, I got another question for you, Dr. Tewari. Um, are you looking at higher indices now of younger men uh, um, having high PSAs and prostate cancer? Is that becoming now more so than before?
I'm not sure if the age of presentation has shifted too much. The average age is still 65, but I have operated on people who have been 36 years of age. So it may be my practice that younger people tend to come to me a lot because of nerve sparing discussions and all those things. But it is not just a disease of in very old men. Very common, I see men below 50 having a prostate cancer. And it's really disappointing for me too. And most of them are men with color or men within family members who have had prostate cancer. So let me ask you, your group, how often do you guys meet?
Well, we meet once a month, and sometimes we may have the opportunity to do a spotlight where we'll meet twice within the month, but we meet once a month towards the end of the month on usually on Wednesday at always at 7 p.m. Um, and we started doing that because we wanted to know more, and we wanted to know the different areas of medical access that men can have. You know, we wanted to know the nutrition part, wanted to know the nerve sparing part, wanted to know the radiation part. I mean, we even wanted to know uh, uh, how other segments of the population of men um, uh, can't have access. You know, like intellectual disabilities. That because some of us in the group, have spoken about that, and it's something that a lot of us have in common. So it's a myriad of questions that uh, for the long and short need answers.
I have a question for the team group here. How many of you are on active surveillance?
No.
No one? I think you should have a discussion about active surveillance because it's a very legitimate treatment option for men with prostate cancer. And if I find 500 cancers a year, my own biopsies, 30-40% of them may need just an active surveillance. But we need to understand what is genomics, what is the biopsy interpretation, what is MRI, what do we do in an active surveillance. It's not in not doing anything. It is doing it only if it is needed discussion. So maybe you guys should have a conversation about active surveillance. Not every patient with prostate cancer needs a treatment, and active surveillance is a very successful. 70% patients never progress, 30% do, and then you can then intervene at that time. So that is one thing. The second thing, I'm so proud in your group. There are more ladies here, and if I ask them question, they will be the one will be more participating in this. Is it okay if I call them out with a name? I see Lisa's phone. I see Rosanna. I see Elizabeth. Do they want to say anything?
Absolutely. Folks, this is your time. Okay, don't be shy. Dr. Tewari is an excellent gentleman, and he's here for you.
Hi, Dr. Tewari. This is Rosanna.
Hi, Rosanna. Thanks for being so brave. I can tell you a lot of men owe it to their female partners who push them out to get the first checkup done and that kind of a thing.
I have a question. I want to know, what are the environmental factors that can actually trigger this dormant gene in the body to become active?
So certain chemicals we talked about, the cadmium is the one, mercury is the one, exposure to carbon and dust is the one, Agent Orange is the one, certain radiation is the one. But there is a but, that exposure to too much of a red meat, exposure to too much of an animal fat, exposure to too much of sugar, and lack of green vegetables and lack of mushroom and lack of pomegranate. I think these are the environmental triggers which push these genes to become cancerous and to become more aggressive.
Okay. I work for the Department of Health, and I work for the lead prevention unit. And there seems to be, correct me if I'm wrong, a correlation between the exposure to lead and prostate diseases in adult males. Have you heard any studies on that?
That's the reason I mentioned that, Tamina. There were certain chemicals, but I used to talk about the mercury level in the fishes and all those things, even sometimes. But I don't want to create a scare discussion. It's just eat healthy, avoid exposures, get yourself checked. That is, but what you are talking about is a very relevant research topic. And I don't want to bring the research fear in community, because we don't know that not every research turns out to be that there is a direct correlation. And the
I
air we breathe,
understand.
I think it's the air we breathe, and same air is being taken in by millions of people, but 1 in 6 or 1 in 7 is getting it. So it's a combination of lot of missteps which are happening. So my role here is to highlight the changeable factors and awareness, and that is what I am trying to focus on. But in
I
the research
understand.
lab, we talk about the genes and the mutations and the entropy and the chemical compositions and the molecular levels and all those things. But your questions are very relevant, Rosanna. But till we have an 100% proof, I don't want to make that as an uh, fact.
Yes. One last question.
Please.
um, for young men that are actually around the age and like in their early 30s, when they go for their annual physical, is it is checking their PSA levels part of the annual physical, or is this a test that has to be ordered
They have to be
separately?
45. They have to be 45 or more if they are men with color or if they have a family member. And then normally they have to be 55 and above. But anyone can have a conversation about the PSA with their doctor. And because PSA discussion is a double-edged sword, because not every PSA needs an intervention, and unless and until the patient and the physician are aware that PSA needs to be talked about, it doesn't need to be acted upon it. Meaning, some people needs a biopsy, some people don't need a biopsy. If you do a biopsy, there is a risk of having an infection or a UTI or something. So PSA is a whole journey. So you just cannot have a PSA discussion without having an in-depth back and forth between the family, patient, and the doctor. So that's the reason we said that let's just start the conversation. They should be aware that something like this is done, but as a fact, 55 and above or 45 and above.
Okay. Well, that was supposed to be my last question, but now I have another question.
Please.
And this will definitely be the last one. So my question is, what should a young man in their early 30s be looking for in terms of prostate cancer? Because there have been men in their 30s that actually have had prostate cancer. So what are the first alarming signals that a man should look for when to alert them to actually get tested and find help?
So before answering that question, I will say to have a prostate cancer in men in 30 is rare. So
Okay.
that is not a norm, but can it happen? Yes. And it usually happens with some symptoms. And the symptoms are they may have a problem in passing urine, they may have pain in passing urine, they may have some blood in the urine, they may have some swelling in that area. But having said these three symptoms, they can happen because of a lot of non-cancerous situations too, like an infection can cause the same thing. Some other inflammatory process can do it. But definitely one of these three things are happening, then they need to be checked by a doctor, preferably by a urologist, and they will pick it up. Having an issue with the sexuality and all those things could be another trigger that can be discussed or need to be further investigated.
Okay. Thank you so much for your knowledge, Dr. Tewari.
You're very welcome, and you can see that you guys are asking more questions and men are just shying behind the mic.
Yeah. I have two questions,
Come on, Kevin.
Doctor, and thank you for your time. One of them I put in the chat. You mentioned prostate cancer in men under 50. What will be is there a common denominator that stands out among most cases that you're seeing? That's my first question.
So they have a family history or they are men with color. They have a father who had prostate cancer, uncle had a prostate cancer, older brother had prostate cancer, mom had breast cancer, some aunt had an uterine cancer. That's a combination.
You mentioned men of color. What will you think contribute to that besides genetics? Could it be like eating patterns, or what? In what age would you want?
Point to one finger on the thing, but it's a combination of things. And red meat is not good, and animal fat is not good. And these two things I can be pretty sure that contributes to it.
So should men of color or particular racial demographics start checking themselves for testing for prostate cancer at younger ages as opposed
45.
to other segments of the population?
45, yeah.
45, okay. And then my other question, and I was looking at the COVID-19 impact on prostate cancer. The chart says it's presence of the virus in seminal fluid. Does that mean that it is possible for COVID to be transmitted saying between a couple having intimacy, if that's the case, that the virus is present in seminal fluid.
It is possible, but has not been responsible for
Okay.
any cases. So you can understand the reason we were looking at it, because we were doing a prostatic biopsies in these patients right where the COVID was floating. I mean, so last year itself, we had to decide who has cancer. So we were wondering, if I poke in into a needle into a prostate which has a COVID hiding there, what will happen? Luckily, nothing happened. But we did study quite a bit of it.
Thank you so much. Everything's
Very
appreciated.
welcome. You're very welcome.
So Dr. Tewari, so if both men on this platform and men that would see this video at a later date, how can they find you in your practice and your team? What are the steps that they have to take to get to that point?
I make things simple. I will give my email to all of you and just reach out to me. I mean, there are many phone numbers, but you can bypass many of them. I mean, you have my email. You just share it with everyone, and even if I don't respond, I make sure that they get it too. You can share my cell phone also. I mean, perfectly fine.
And I know you're being modest, but you have a tremendous team. You have a push-up challenge. In the hospital, they will put any man to shame. Can you explain or tell some of these men how many push-ups can you rip? Because it's I'm not kidding, guys. Dr. Tewari, he can definitely do push-ups.
I think it's important for us to exercise, and our body, the good chemicals are being made in our muscles. And I'm not meaning that the Arnold Schwarzenegger kind of in muscles, but the Bruce Lee kind of in muscles are our friends. We become limp because our muscles gave up. We become like this because our muscles, they keep us in a normal posture. We move around, our leg muscles are helping us. So, exercise, our heart, our lungs are important. And I personally invest 4 hours to 5 hours a week in exercise, decent exercise. And I believe sleeping is important, eating right is important, exercise is important, and having a meaningful family life is important. All that thing combined. But and you cannot pay your someone else to do exercise for you. You have to do it yourself. So, and start small. I spend time in either walking or peloton, and people say that I don't have a gadget, I don't have a machine, so that's the reason I started talking about push-ups. I can easily do 50, 100 push-ups just because I started doing it. And it's just start one or two or three. I'm a big believer about training and not straining. I would rather do five less than what I can, but do it 5 extra days than one day too many and then get hurt next day. So slowly phase in into exercise. It's a healthy thing, and eating right is a good idea. And it's not just about the the diagnostic test and imaging and robots. It's all about the lifestyle balancing it. And I have to kind of set up an example rather than just preaching you guys.
Well, certainly. Thank you so much for sharing this very important information with all of us, and we will definitely like to have you back here again at a later date um, uh, uh, when you can, because there's like so much to learn on this topic. Um, but thank you again, Dr. Tewari, and for coming. We've been very blessed to have you on our platform here.
Yeah, you guys are doing something very meaningful. We are like friends and brothers. We are all the same group. And anything I can do, anyone needs to reach out, feel free to share my cell phone, my thing, and my website has all the addresses for the rest of the team. And I'll be happy to come. And that's the reason I didn't want to give a lecture. I just want to talk and connect with you guys. And if you want to thank me, go out and exercise for half an hour. That's it. That's all I need. Thank you.
Thank you, Dr. Tewari.